A 34-year-old woman present with dry cough and exertional breathlessness for the last 4 months. Initially mild, the symptoms gradually progress. She also reports low-grade intermittent fever, fatigue, and unintentional weight loss of around 4 kg. There is no wheeze, no chest pain, no hemoptysis. She has no history of tuberculosis or smoking. On further questioning, she mentions episode of redness and pain in both eyes over the last few weeks and weight joint pain involving ankle and knees. There is no morning stiffness, no skin rashes or nodule by history. On examination, vitals are stable with oxygen saturation of 96% or low air. There is mild pallor, no lymphadenopathy and no hepatosplenomegaly. Eye examination shows conjunctival congestion. Chest examination reveals bilateral, fine and inspiratory crackles more in upper zones. Other system examination are unremarkable. At this point, I usually pause and ask chronic cough, fever, weight loss, eye and joint symptoms. What are your differentials? So now investigation. So hemoglobin of 10.8, normal leukocyte count and ESR of 65. Liver enzymes are largely normal except mild elevation of alkaline phosphatase. Serum calcium is 11.4 with suppressed PTH. Renal function normal. Chest X-ray reveals bilateral symmetrical hilar lymphadenopathy. HRCT shows bilateral hilar and mediastinal lymphadenopathy with peri-lymphatic nodules along with bronchovascular bundles without cavitation or necrosis. Given our setting, tuberculosis is ruled out. Sputum AFB and CB-NAT are negative, Muntux negative, ACE level are elevated. Ultrasound guided lymph node biopsy shows non-caseating granuloma with no evidence of tuberculosis or fungal infection. So the diagnosis becomes clear, sarcoidosis. She is symptomatic with pulmonary involvement, ocular symptoms and hypercalcemia. So oral steroids are initiated. Calcium intake is restricted and ophthalmology referral is done for uveitis. Over the next few weeks, her cough improves, calcium normalizes and fatigue reduces. So the key learning points are: number 1, not all bilateral hilar lymphadenopathy is tuberculosis. Symmetrical hilar lymphadenopathy with multi-system involvement should raise suspicion of hypercalcemia with low PTH is important clue. Tissue diagnosis is mandatory before starting steroids. And sarcoidosis is a diagnosis of clinical, radiological and pathological correlation. Thank you.